Okay, let's complete the disorders associated with the immune system. We'll complete this in Chapter 19. This is Part B. Let's talk a little bit about acquired immunodeficiency syndrome. You've already watched the video clip of the HIV virus, how it attacks the human cells, but let's give you a little historical data. Again, that little video clip that you watched during the lab, this was several lab assignments ago, helped familiarize you with the condition. In 1981 in the United States, clusters of pneumocystis carni, or Kaposi sarcoma, in young homosexual men was discovered. The men showed a loss of immune function. In 1983, a discovery of a virus causing the loss of the immune function. This is the acquired immunodeficiency syndrome virus. Again, as you can see, the nuclear network in this system is composed of RNA. You have the enzyme, reverse transcriptase, the envelope, the structures, the GP120s, adherence factors for this organism that are able to attach or fix to human cells. This coat is shedded as the cell passes into the human cell, eventually arriving to an intranuclear location where this same enzyme is utilized to use our own genetic material to multiply inside the host cell. The origin of HIV disease also was discussed on the video. Just as a brief review, it crossed species barriers into humans in Africa in the 1930s. Now you notice it says it crossed the species barriers. Remember the talk now, or understand the talk now about the bird flu virus and the ability of certain viral agents to cross species barriers, seroconverts into a disease that can cause, that can become pathogenic in humans. Patients who died in 1959 in the Congo, which is the oldest known case of HIV, spread in Africa as a result of urbanization, is spread in the world through modern transportation and unsafe sexual practices. A Norwegian sailor died in 1976 is the first known case in the Western world. This is an example of HIV-infected cells. Again, please watch the video clip, and I believe that was in the second or third lab assignment that showed the process of HIV and how it infects the human cells. The acquired immunodeficiency syndrome is a type of immunodeficiency disease, as we discussed in the previous lecture. It is caused by a human immunodeficiency virus. It destroys helper T cells. Now, these are the cells in the immune system that typically would help fight infection. AIDS is the final stage of a lengthy HIV infection. At this time, the loss of effective immune system leaves the victim susceptible to a variety of opportunistic infections. That's why we mentioned early on pneumocystis carni. Pneumocystis carni is considered an opportunistic infection. HIV is a retrovirus. It requires an enzyme, reverse transcriptase, to form DNA from its RNA genome. You're already familiar with that. The envelope of the HIV disease has spikes, or the GP120s, which I showed you in an early illustration, that allows the virus to attach to the CD4 receptors found on the helper T cells. It's important to recognize this, and again, this is a review from the video you studied in the lab. There are also co-receptors such as CXCR4 and CCR5. These also may be required for such infections. Attachment followed by the entry into the cell where the viral DNA is integrated into the DNA of the host cell. It may cause new HIV infections by budding from one T cell, or it may remain latent as a provirus. HIV is capable of very rapid antigenic changes. Worldwide, HIV is beginning to separate into groups or into clades or subtypes. There are now 11 clades or subtypes of HIV virus. HIV-1, the most common and major type, HIV-2, which is relatively rare in the United States, though some cases are still reported. I won't go through each of the steps here of the HIV infection. Again, refer back to your lab and review the material, or review the video clip that describes this process of HIV infection. Now, the stages of HIV disease, again, it's a period of several weeks to months pass before seroconversion occurs. This is when the antibodies will first appear to HIV. Remember the definition of seroconversion. This is our body has mounted now an immune response where it develops antibodies that would attack a foreign invader such as the HIV virus. But recognize that HIV disease also attacks the immune system, so even though antibodies to HIV are being developed, the virus quickly goes to an intracellular location, and so our immune system cannot recognize the virus any longer because it's not on the surface of the cell. It's actually inside the cell, and the surveillance mechanism that typically our immune system uses is no longer effective. Also, while the HIV virus is in the intranuclear location, it begins to multiply, and it also destroys the immune system cell in which it is occupying. CDC has classifications of clinical stages of HIV disease. Category A is asymptomatic or persistent lymphadenopathy. Lymphadenopathy refers to a term where the lymph glands are actually swollen. Category B, persistent Candida albicans infection. Now, Candida albicans are a yeast infection, also an opportunistic organism that's inside our body. We all have Candida and yeast in our mouth and in our gastrointestinal tract. We have it almost in every mucus-lined cavity in our body. However, our normal flora, or the bacteria that's normally in our system, competes with Candida for an energy source, and because our established normal flora is of higher concentration and number, Candida albicans cannot grow. However, in an HIV infection, when we have a compromise in our immune surveillance system, then this persistent Candida albicans can develop. So patients with HIV disease can present with thrush or Candida in the oral mucosa, vaginal mucosa, rectal mucosa. Category C, clinical AIDS, or CMV, TB, pneumocystis, or toxoplasmosis, or Kaposi sarcoma. Again, pneumocystis carni and toxoplasmosis would be opportunistic infections. Kaposi sarcoma we'll talk about specifically in the future. So, category A, these infections may be asymptomatic or cause persistent lymphadenopathy. Again, that's a swollen lymph node. Category B, which is persistent infection by Candida albicans. Patient may also have shingles, persistent diarrhea, fever, and certain precancerous conditions. And category C, which is referred to as clinical AIDS, indicator of conditions such as pneumocystis carni pneumonia. Remember, A being asymptomatic, C, clinical AIDS, the appearance of opportunistic infections such as pneumocystis carni pneumonia. CDC also classifies mainly for clinical guidance such as drug administration, the progress of HIV infection based on T-cell population. Now, the normal population of our T cells, which is measured in what's called the CD4 count, is around 800 to 1,000. From infections to HIV can take up to 10 years to evolve in some individuals. So an exposure up to 10 years can lead to a seroconversion, where our body will begin to form antibodies against the HIV virus. This illustration out of your textbook is important for you to review. It demonstrates the stages of HIV disease and goes through the categories or classifications that's used by the Center of Disease Control, or the CDC. Category A, again, is asymptomatic. You may have some chronic lymphadenopathy. Category B, symptomatic, early indication of immune failure. And category C, full-blown AIDS. Again, the progression of the disease is shown in years, represented on the horizontal line. Vertical line represents the CD4 count. And note the time span, and note the CD4 count has progressively fallen. Again, we want a level between 800 and 1,200, which would be considered normal. Individuals with full-blown AIDS typically have CD4 counts are lower than 800. Now, this is just a representation of an HIV infection. Recognize individuals may get exposed to the HIV virus for a very short period of time and have a significant drop in their CD4 count. It does not have to be years. You don't have to have a 10-year latent period before the onset of infection. It can occur after 1 month, 2 months, 3 months. Rarely does it occur before the 1 month part, because the viral load, the amount of viral copies that have to be made by the HIV virus, have to reach a certain point to be able to attack the immune system. So rarely would you see a case of full-blown AIDS after 1 month of exposure. I'm not saying that it's not possible, but it would be extremely rare. Typically we have a growth phase of the HIV virus over several months. Important to recognize each of these steps and just be somewhat familiar with the graph, particularly the categories here of HIV virus, the importance of monitoring the CD4 count, and the progression of the disease. Some common diseases that are associated with HIV disease or AIDS: Cryptosporidium, which causes persistent diarrhea; Toxoplasma gondii, Isospora. All of these cause significant infections, two of which, as you can see, the Isospora and the Cryptosporidium, both cause a form of gastroenteritis and diarrhea. You can obviously see diarrhea here with gastroenteritis. Cytomegalovirus, herpes simplex virus, varicella zoster virus, all of which can lead and can be seen in HIV disease. Mycobacterium tuberculosis, you're already familiar with. A form of mycobacterium called avium intracellular may also be seen with patients with AIDS. Fungal infections include pneumocystis, which we talked about earlier. Pneumocystis carinii pneumonia, or a type of pneumonia related to pneumocystis, can certainly be life-threatening. Histoplasma capsulatum, Cryptococcus, Candida infections also can be seen as fungal infections in HIV disease. And cancerous or precancerous conditions such as Kaposi sarcoma, hairy leukoplakia, and cervical dysplasia can also be seen. Now, I'm not putting this table up for you to have to memorize each of these types of opportunistic events that can occur with HIV disease. However, you should be able to appreciate the fact, as a clinician or healthcare provider, when you see an individual comes into the clinic and gets diagnosed and has persistent diarrhea, and cultures demonstrate a Cryptosporidium organism, red light should go off that this person needs HIV testing. Now, herpes simplex virus is a much more common virus that we can see in a normal, healthy population of people, as can we see varicella zoster or shingles in normal, healthy individuals. However, if you saw a combination of toxoplasma, if you saw Cryptosporidium, and then you also saw herpes simplex virus and CMV, it's the constellation of illnesses or pathogens that you see that, again, certainly should put on some red lights for you to test the individual for HIV disease. Remember, we talked about Candida albicans as an opportunistic infection that we could see with the use of antibiotic therapy. Person takes 10 days of antibiotic therapy for an upper respiratory infection, can develop Candida albicans. Certainly Candida albicans yeast infections, vaginal yeast or monilial infections related to Candida are very common in a normal healthy person that's taking antibiotic therapy. However, if you saw Candida albicans overgrowth in the mouth and you also had a comorbid histoplasma infection or pneumocystis infection, again, it would be the pattern of diseases that present themselves that should make you recognize HIV disease as a possible etiology. Mycobacterium tuberculosis, not an uncommon infection that's seen in the United States these days as well. However, Mycobacterium avium intracellular is a completely different animal, though it's in the family of Mycobacterium. If you see this organism, Mycobacterium avium intracellular, then certainly red light should go off, because this is not a common infection that you see in a normal healthy individual. Now, a normal healthy individual can develop Mycobacterium tuberculosis. We as healthcare workers are exposed to Mycobacterium tuberculosis in healthcare settings, and so it would not be uncommon to see a seroconversion for a person with Mycobacterium tuberculosis in a healthcare worker. However, Mycobacterium avium, a different animal, and if you see this, then certainly red light should go on for HIV disease. Certainly Kaposi sarcoma, Though Kaposi's sarcoma can be seen in patients that are on immunosuppressant therapy for different types of cancer. You also may see a person that's on immunosuppressant therapy for a transplanted organ. And so these individuals would also be at risk in developing Kaposi's sarcoma, hairy leukoplakia, and then also cervical dysplasia. Now remember, cervical dysplasia is not an uncommon finding in females as well because of the human papillomavirus. The human papillomavirus we'll discuss later when we talk about the genital urinary system and diseases, and infectious diseases related there. But cervical dysplasia would not be an uncommon finding. So an isolated cervical dysplasia in the absence of these other pathogenic diseases would not necessarily be uncommon in a healthy individual. But if you saw cervical dysplasia, you saw a cryptococcus infection, you saw herpes simplex varicella virus, or Mycobacterium avium as other constellations or other diseases that were also related there, then certainly red light should go off on warning for testing the individual for HIV disease. One important manifestation of fungal diseases too that I skipped over, and it's important, is cryptococcus. This is a disseminated form of fungal infection. It can cause certain types of meningitis. There's also a dermal or skin manifestation of cryptococcus as well that's pretty recognizable in individuals with HIV disease. Again, seroconversion takes up to 3 months. And if you recall when I showed you the graph, again I told you rarely would an individual have full-blown AIDS within a month after exposure. Seroconversion can take up to 3 months to occur. Now, it may occur quicker than this, but most commonly we see a 3-month mark. HIV antibodies are detected by ELISA, as we discussed earlier. HIV antigens can be detected by Western blotting, which we also discussed earlier. Plasma viral load is determined by PCR, or nucleic acid hybridization. PCR we talked about in earlier lectures. If you don't remember PCR, you should go back and read that. Polymerase chain reaction. Polymerase chain reaction. Should be familiar with that. The most commonly used screening tests are versions of the ELISA test, which are confirmed by Western blot. That's important, and you should know that. I know that's a test question. A problem with antibody type tests such as these is a window of time between infection and the appearance of detectable antibodies. HIV transmission requires a transfer of or direct contact with infected bodily fluids. Routes include sexual contact, blood-contaminated needles, organ transplantations, blood transfusions, etc. Again, must have contact, direct contact with infected bodily fluids. In contrast, plasma viral load test detects quantity of HIV circulating in the blood and minimizes the window during which HIV infection cannot be detected. HIV transmission. HIV survives about 6 hours outside the cell. It also survives for greater than 1.5 days inside the cell. Infected bodily fluids transmit HIV via sexual contact, breast milk, transplacental infections of the fetus, blood-contaminated needles, organ transplantations, artificial insemination. Again, this is transmission of bodily fluids, and then also blood transfusions. Now, this is an older graph. I'm not going to ask you a test question off of this. Well, I shouldn't say that. I will probably ask you something about the modes of transmission for HIV transmission, but just recognize this chart has changed. It evolves over time. By the time the textbook is produced, years have passed, and so some of the statistics change. Now, certainly men who have sex with men is still a high category of prevalence of HIV transmission. However, the injecting of drugs is the largest growing population of individuals that get infected by HIV disease. Heterosexual contact is also a high category as well. Other causes, men who have sex with men that inject IV drugs. Recipient drugs, as you can see, this number is very low and continues to fall as the screening techniques for blood has certainly improved over the years and since the time this virus was originally identified. AIDS worldwide impacts the United States, Canada, Western Europe, Australia, Northern Africa, and South America. Injecting drugs or male-to-male sexual contact being the etiologies. In the sub-Saharan parts of Africa, we see it's primarily heterosexual contact. There are a number of complications related to the ability to treat HIV disease in sub-Saharan Africa. Poverty, famine are huge issues. Remember, you have to have an intact immune system to be able to fight off any type of infection. If you're dealing with a country that has famine as a significant problem, cause of not only disease and death, but also complicating the fact is that it damages the immune system. So the ability to fight off any infection is poor at best. Also, the funding, poor countries, developing countries such as the sub-Saharan parts of Africa don't have the funding to treat HIV disease. It's an expensive disease. It takes 4 drugs at a minimum to treat this virus effectively, much less the healthcare workers that would need to be available to educate people in being compliant with their medication regimes. Treating HIV disease requires surveillance labs to be done to measure CD4 counts and to assess individuals for opportunistic infections, and then to be able to give treatment for the opportunistic infections, which would involve more money and more drugs to be able to combat this. So you can see the problem is too overwhelming for sub-Saharan parts of Africa. The infection here, though I may sound pessimistic, the infection in this part of the world is probably beyond even a world response at this point. The expense required, the number of drugs required, the importance of compliance with drug regimens, the ability to have surveillance labs done on individuals infected is far beyond the reach of these developing countries. The expense alone in the United States and in other countries in Canada, Western Europe, Australia, Africa, and South America already has a huge demand on those countries as well, much less to try to treat a population of individuals where HIV disease is endemic. In Eastern Europe, in the Middle East, and Asia, injecting drugs in heterosexual contact also are causes of the virus to spread. As you can see worldwide the number, and then you can see the concentration in the sub-Saharan parts of Africa. Again, not to be too pessimistic, I think this is beyond even a world response. Neighboring countries here are constantly in war. There are warlords in these areas that have money as the priority, much more so than taking care of human health. Remember, these are countries that actively participate in genocide as well, and so there is no, in some of the countries, there is no compassion for trying to treat people with diseases when you want to wipe out a certain tribe. So it complicates our ability politically to be able to get into these areas and provide adequate treatment and care. HIV-1 is the most common, has 11 clades. 90% of the U.S. infection caused by the clade B. That's important. Clade C predominates in sub-Saharan parts of Africa. Clade B, C, and E are in South and Southeast Asia. HIV-2 is seen in Western Africa. The use of condoms and sterile needles is important in the prevention of AIDS. Healthcare workers use universal precautions typically when taking care of patients with AIDS. They wear gloves, can wear gowns, masks, goggles, depending on the amount of exposure to blood. Certainly in cases of multiple trauma, in emergency rooms where there's a significant amount of blood being spilled and contaminating other surfaces, the use of universal precautions, the full gear of wearing gloves, gowns, masks, and goggles is required. Also important to understand, needle sticks are the #1 cause of transmission of HIV disease in the healthcare workers, so it's important not to recap needles. I've seen a variety of needle sticks related to the process of recapping a needle, putting the top back on a needle, and people inadvertently puncture themselves. The procedure in almost every hospital in the United States now is not to recap needles. These needles should be disposed of and sterile in the appropriate container immediately after their use. Many hospitals have converted to what's referred to as needleless systems. And you'll go into much more detail about that as you progress in your healthcare professions. The risk of infection from infected needle sticks injury is about 0.3% overall. That number doesn't sound very high, but recognize it's the number one cause of transmission in healthcare workers. Vaccines are in clinical trials at this point. Thus far, no real success has been made in the development of vaccines for HIV disease. Whole cell salmonella, GP120 gene. Remember, GP120 are the spikes that we see on the cell surface of the HIV virus that help to adhere to receptor sites on the human cells. Subunit vaccines using GP120 expressed in Saccharomyces. These are fungus that are used to provide a medium for developing vaccines. The canary pox virus with HIV capsid protein genes has been used. Again, remember, if we could get our body to just recognize a part of the virus, it doesn't have to be an active virus. Remember when we talked about vaccines, they can either be attenuated or they can just be components of the infectious organism that our body would recognize as foreign invaders and thus would be able to mount an immune response. So in the canary pox virus, the capsid protein genes is being utilized in research. Naked DNA consisting of a transcription factor referred to as TAT or GAG, which is a capsid protein. Again, this is looking at a fragment of a virus that would be able to be recognized by our immune system. These are all under clinical trials, and again, there's no significant headway at this point. Much of the progress has been made with the use of chemotherapy to inhibit HIV infections. None of these can be considered a cure for HIV disease. However, I see patients in clinic now that have had HIV disease for 20 years or more, and again, on the appropriate medication, though the disease is not curable, it certainly is treatable. A special target is the enzyme reverse transcriptase, not present in humans. Drugs of this type, nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and other groups such as protease inhibitors are also known and can be used. Again, chemotherapy, nucleoside reverse transcriptase inhibitors. Remember, reverse transcriptase, important enzyme in the replication of the HIV virus. If we can have an inhibitor of this enzyme, we can thus destroy the multiplication of the virus. Non-nucleoside reverse transcriptase inhibitors, same philosophy. Protease inhibitors, again inhibiting the enzyme that's important in the protein synthesis in the virus. And then virus decoys. You should be familiar at least with the first three as far as chemotherapy. Nucleotide reverse transcriptase, commonly referred to as NRTI types of drugs, and also the NNRTI drugs, the non-nucleoside reverse transcriptase drugs. You should be familiar with those two categories. And then thirdly, you should be familiar with protease inhibitors, important chemotherapies in the treatment of HIV disease. The current treatment regimens involve the use of several drugs simultaneously. These are called highly active antiviral or HAART therapy, which minimizes the effect of rapid development or the resistance of HIV disease. You should be familiar with this term, highly active antiviral therapy or the HAART therapy. The current treatment regimen involves several drugs. These can be, as we looked at previously, can be nucleoside reverse transcriptase inhibitors, can be nucleoside or non-nucleoside reverse transcriptase inhibitors, or can also be protease inhibitors. These are HAART drugs, chemotherapy used in the treatment to manage HIV disease. Highly active antiviral therapy, or the HAART regimen. Combination of nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and or protease inhibitors.